Cutting-edge technologies such as wearable devices, mobile apps, and cloud platforms are revolutionizing the healthcare industry. Such a development will change the way patients track their health, the physicians provide services, and the communities share information. We believe that the key to improve healthcare quality while minimizing the cost lies in mobile technologies, artificial intelligence, and big data analytics. Let us welcome the professor, Mr. Ting Shih, to open the floor for the mobile health panel discussion. Mr. Shih was named the 2015 Toyota Mother of Innovation. She holds an MBA from the MIT Sloan School of Management and a master's program in systems engineering from MIT. Mr. Shih is also the CEO and founder of ClickMedix, a company that uses mobile technology to fill in the needs for medical expertise in some of the most remote regions around the world. Welcome.
Good afternoon, everyone. Thank you for staying around for the conference event. We've heard such exciting topics from AI to virtual reality and robotics. And in this panel, particularly mobile health, we're going to look at how various perspectives and technology can solve one of the most important problems of our lives, and that is our healthcare. And my name is Ting Shih, and when I'm actually a graduate of Carnegie Mellon in computer science, went on to pursue a master's at computer science, worked in industry for a while, and then I went to the other school, MIT, to pursue my MBA and another master's in systems engineering. And at MIT, in one of the classes, I was posed with a very simply stated challenge, and that was create a business that will impact over 1 billion people in healthcare. So I thought, when we look at a problem that huge, technology had to be one of the components of the solution. And hence, I created a mobile health platform that helped doctors deliver care to more people. Currently, and it's called ClickMedix, currently it serves over 300,000 patients around 18 countries. And we have about 3,000 doctors, health workers, and caregivers delivering healthcare around the world. And what's so exciting about today's panel is you're here from the healthcare perspective, technology perspective, big data, artificial intelligence, as well as the global healthcare perspective on how we can actually improve what's so important to us, which is healthcare for us as well as for our loved one. So without further ado, I'd love to have each of the panelists introduce themselves, taking 2 to 3 minutes, and then we'll go over sort of the journey for how we can solve problems in healthcare.
All right, thanks, very nice to be here. I'm Bian, I'm from China. You can call me Harry, make it easy. And I'm the product and technology leader of the Wingspan. And after my graduation, all my 15 years working experience is about medical imaging IT solution development and the product management. Let me take a little bit of time to talk about the company Wingspan. It's a Chinese company. It's founded in year 2009, and it provides the medical imaging software and service. As I said, it provides the on-premise and cloud-based medical imaging solutions. So in the last 80 years, it connects more than thousands of the medical machines, the CT, MRI, X-ray, and ultrasound. And besides that, we have, in terms of number, we have the biggest internet-based radiologist group. So that means that we also provide a remote image diagnosis service as well. And from this year, we got the third-party image center license. That's a new thing in China. I know that's not new in USA. So all together, I mean, with the third-party image centers, with the medical image IT solutions, and together with the radiologist, Wingspan provides the end-to-end medical image services. From the last year, working with our partner, one of the partners is the Professor Xing's company, Patientoriented. So we are trying to leverage the AI or machine learning to do something. One thing is that is improve efficiency, workflow efficiency. The other is the quality up. I mean, to reduce the misdiagnosis rate. So we believe, I think we can make a difference, something here, and to make life better. Thank you.
Hi, my name is. Hi, my name is Joel Silinicchio. I'm a physician in practice, a pediatrician at Georgetown Hospital in Washington, D.C. I'm also the co-founder of a company called Magpie, which provides mobile data software for a lot of international health organizations like the World Health Organization. I've spent my career for about the last 20 years working in technology, working in clinical medicine as a practicing doctor, and also working in public health, which is sort of the health that happens outside of the clinics, outside of the hospital systems. And that is mostly in developing countries. What's been really interesting, I think, in the last 15 years especially, has been the convergence of the technologies that we use in poor countries to affect health, like smartphones, and the technologies, of course, that are making more and more of an impact on health here in the United States. Again, this kind of convergence between rich and poor countries. I'll look forward to discussing this during our presentation. Hi, I'm Steve Shapiro. I'm Executive Vice President for UPMC, Chief Medical Scientific Officer, and President of the Health Services Division. I came to Pittsburgh about 10 years ago from Boston. As a matter of fact, I just came here to be polite. I knew something special was going on in Pittsburgh, but I wasn't going to leave Harvard. I had a great job there. And then I thought that the structure and culture, UPMC and Pitt, was really the winning culture for healthcare reform. I had no idea healthcare reform was going to come upon us so dramatically. But I really do think it's the right structure and culture. Structurally, the way UPMC is built, we've got a health services division, which is my division, which includes all of our doctors, which is Bruce, about 4,000 employed, and other people, number affiliated, about 40 hospitals and growing. We're the largest academic medical center in the country. We also have a health plan, the only academic system with a really large health plan. We're 3 million members now, the largest in Western Pennsylvania. And we also have an entrepreneurial arm, which started the Help Day Alliance with CMU, with UPMC as the umbrella, because we do see, in some ways, medicine turning into a software platform, and we'd like to be that operating system. We also have an international arm. We're in about 12 different countries, very much interested in China. Notice several of you are from Tsinghua. All of the medical students from Tsinghua University come to Pittsburgh for 2 years to do research. So a lot of interesting international opportunities. But at any rate, it's really a pleasure to be here and look forward to this conversation.
I'm Eric Xing. I think I introduced myself already this morning, but maybe I'm going to say a little bit about my other life, right? So I'm also a fan of healthcare research. I was the founding director of a center called Center for Machine Learning and Health, together with UPMC and also with the University of Pittsburgh 2 years ago. I'm no longer the director because I'm now also wearing the hat of a CEO and chief scientist of a company called Patientoriented, whose goal is to not only providing the operating system for machine learning and artificial intelligence on different hardwares, but also to provide, in some cases, vertical solutions to the healthcare space. Some of the work we did includes, generating machine learning programs and systems to understand doctors' notes, understand, X-ray pathology, mammogram images, and also to integrate, those information with medical literature, with medical background knowledges to provide second opinions on diagnosis and drug recommendations or other treatments. So we used to work with Steve a lot, and I look forward to continue that collaboration.
Hi, my name is Bruce Goldman. I'm a primary care physician, and I'm professor of medicine at the University of Pittsburgh and director of our Center for Behavioral Health and Smart Technology. Most of my time at the university is spent conducting clinical trials, doing research, on behavioral health and mental health conditions, and specifically treating depression and anxiety in primary care and in patients with heart disease. We recently finished, my team and I recently finished an NIH-funded trial looking at the impact of using UPMC's Beating the Blues computerized CBT program, along with an internet support group that allowed UPMC patients to communicate with one another on a password-protected website through a smartphone or a desktop computer. And probably one of the biggest things we learned, and we'll talk about more in the panel discussion, is about engagement with the technology. People here can build the very best and shiny new programs and so on, but the key thing is to get people to engage and come back to those websites and use the programs. In fact, although I can't see too well because of the light, I see some people are on their cell phones in the back. So I mean, this is really an issue, trying to get people to engage with our speaker panel, and we're competing with cell phones, so we have the same thing with our patients and trying to get them to participate in their own health. So thank you, and I want to thank the organizers for inviting me to be here today.
Great, thank you so much for all of your introduction. And we'd love to start from the healthcare perspective, particularly from Steve and Bruce's perspective, and you've already started discussion. Where do you see the biggest challenges in healthcare that could be addressed by technology? And also, to your point, what are some barriers for adoption? And I see that as probably one of the hardest problems to solve, because we don't have a shortage of technology. So how do you pick the one you need, and how do you get them to be used?
I think everything is people, process, and technology, so it could be involved in all of our problems. So what's the biggest problem in healthcare? I think if you just look at the repeal, replace, we won't get too political here, but you really can see that it's really hard to provide healthcare for all that's affordable, which isn't necessarily the goal of the AHCA, while not bankrupting the country. So the problems of, we have to move to value-based care, better outcomes at a lower cost. We can't spend 18% of the GDP in climbing. So how do we do that? How does technology play a role? And the real clue is to really move to population health. If we try and keep patients healthy, I have to tell our medical students that hear this, that we're so costly and our outcomes aren't great, and I can guarantee them that we're really good. This is the best place in the world to get really, really sick. We could fix you up and then send you on your way to get sick again. But to have coordinated care, to move that care out to the home, to keep patients healthy at home, requires mobile technology to continuously monitor the patient so that they don't get sick again. There are many other ways in which technology can play a role, particularly with the AI that we've talked about before. Having that crystal ball, long-term goal, that could tell the patient all the diseases that they're at risk to getting, and when they have them, what's the course of their disease and the best treatments for them. But technology would clearly be needed to solve these problems.
I'd like to follow up on Steve's remarks with population health, and what we think about are the social determinants of health. And according to these theories on the social determinants of health, only about 10% of human health is really directly related to the medical system, and the rest is related to things like having clean water, clean air, safe neighborhoods, vaccines, and other kind of preventive health measures. And I think that the challenge for some of the mobile health kind of platforms is not just tracking people in the hospital or when they're acutely sick, although certainly chronic care is important, but somehow developing, how would you say, wraparound technology. So say, for example, when you go to the supermarket, if you're using Apple Pay or something else, your credit card to pay, somehow it's related and you can make better choices. Maybe there might be incentives to buy more fruits and vegetables and less on sugary sodas and so on. Or maybe there might be, like UPMC and many other health integrated healthcare delivery systems have all sorts of incentive programs to stay healthy, like walking and so on. And maybe there might be ways of having the smartphone as a digital hub and to pull that information, not to be siloed, but to develop the standards that would allow that information to go into the electronic health record, to go into the cloud and so on, and then give actionable real-time feedback to people to keep them healthy, as well as if we know that they have a chronic disease, to keep them adherent with their treatments, be they medications, food, or sleep, or something else.
And I think that makes great sense. We've just done, last year we worked with DC Greens in DC, basically as part of the government food voucher distribution program. So the patients actually are part of the welfare program. They come and with their ID card, which would be Medicaid, one of those, they swipe in, they get $5 of check to go buy fruits and vegetables in the market. And then we're tracking their health over time. And part of the success for that is that the government is paying for it. ClickMedix provides the technology so that this distribution process can be authenticated, it can be generated, and it can be tracked, as well as seeing how the population outcome is going with a program like that. And I think it's absolutely fascinating because what we've seen in so much of our work is that patients don't really want to pay for healthcare. Nobody really wants to pay for healthcare, but they're happily buying, $300 to $500 of Apple Watch devices and foods and restaurants. And a wraparound angle, I think it's really fascinating. And maybe just to follow up on that, you mentioned the patient engagement part. What have you seen that actually worked? And is it coming from likes of UPMC or the startup community or somewhere else where there are mobile applications where people are using and seeing outcomes? And I welcome anyone to comment from the panel on this as well.
So I think just to second what you had said about the idea that 90% of, I don't recall exactly, but correct me if I'm wrong, that 90% of people's health, or the determinants of people's health, don't really have anything to do with what you term the medical system, what we also in this discussion have called the healthcare system. And I think it muddies up the discussion when we confuse people's health with the so-called healthcare system, which in general is a system for dealing with people's sickness. I mean, right now, I think for anybody in the audience, especially since it's a young audience, the vast majority of determinants of the health of everyone here has really very little to do with the 5 minutes that you spend every year seeing your doctor, if in fact you go to see the doctor for 5 minutes a year. So I think, as a doctor, it kind of, in one sense, pains me to recognize that the technology industry and artificial intelligence, etc., are going to find ways to get around the patient engagement issue that aren't going to come necessarily from doctors. There was a discussion earlier about artificial intelligence and the fact that artificial intelligence can often lead to software that solves a problem in a way where we cannot explain how it does it. What is the pathway that it does to solve that problem? I think certainly that's going to be applied to these issues of patient motivation or just people motivation in terms of health. So I really see that a big part of this is going to be a shift of, an even greater shift of this away from the healthcare system. I don't know whether that means into the startup community or is it going to be some kind of collaboration between the two, but a big change.
Just a quick plug for Carnegie Mellon. One way to get patients engaged, and I would say physicians as well, is through game theory and gamification. Don't underestimate the ability for you to create apps that will engage a patient. Because if we don't get patients engaged in their health, then it's going to be very difficult. It's really difficult to have a healthy lifestyle. But if we can get rid of smoking, people eating better food, and exercising, maybe we'll throw in sleep, you could get rid of 90% of these chronic illnesses. And to do that, we need to have people pay attention.
I think to add on to what Steve said, I've been very intrigued by the ideas with behavioral economics. Is there a show of hands? Are people familiar with these ideas? There's a professor here by the name of George Valenstein. He's probably not in the audience, but he's a Carnegie Mellon professor who works with Kevin Volk at the University of Pennsylvania, where they have a center on behavioral economics and smart incentives. So they've tested all these ideas in randomized trials, like using lottery systems, using doing contests, loss aversion, and other kind of things to kind of motivate people to do behavioral change. And they find that some of these things, like loss aversion, where you have something and you might lose it, works better than saying, hey, if you complete this survey online, you'll get paid more money. So there's kind of like tricks and framing techniques. I think there's a very famous one about getting people in the United States to save more money for retirement California had changed some of their rules where they had like state employees are automatically enrolled in a retirement plan unless they opt out, while previously people had to opt in. And making these kind of small, almost no-cost changes made a large impact on the amount of money that people saved in their retirement program. So I think we need to be a little bit more clever, and some of these could be paired with some of the inventions that people here develop to get people to use the product, because you can spend a lot of time developing your software or other innovation, but if people won't use it, then it's not going to be that effective.
Yeah, thank you for all of your comments. And I think it would be good to kind of drill down to some of the solution. We talked a lot about artificial intelligence. It would be great to hear from Eric again, as well as Henry. What are your thoughts on how AI can be applied in healthcare? And particularly, what have you seen as some evidence or correlations that could actually be used in today's environment?
Well, maybe I can just follow up what was in the discussion just now. So I think that the way right now people see, or the community see AI or computer science in general has been a little bit ambiguous, because on the one hand you can create mobile apps based on a smart deployment model or business model to engage the patients and collect their data. And that's in fact, in my opinion, outside of the AI research, because they are more resource and strategy dependent. But then there is another part, of the computer science or AI production, which is the algorithm and the solution and the mathematical part of that, which is actually to many people a crystal ball which can be created or maybe exist already somewhere, and it's about mounting them to an existing vehicle and kickstart the process. But actually, the story is not as simple. To create AI solution, there is a huge need for the AI solution creators to be in the full pipeline of data generation, deployment of solution, and also testing of the solution, and also iteration of that. Right now, as a creator or maybe an enabler of some of these technologies, my personal experience tells us that it is very hard to actually bring us into this full ecosystem to be an integral part of the solution. For example, it is very hard for us to get sufficient amount of data, and also to get people to test run our solution and give the feedback and iteratively in a stable fashion. Very often, the policy restriction, the resource restriction, or even approval of access to data will take months or years. And that's actually now a major bottleneck for the innovation in AI. So for my own company, for example, we actually right now rely more on the very, very limited amount of open data, like the mimic data set that is public, to create a prototype of our image recognizer, our electronic healthcare node processing system, and drug recognition system. But we limit on the fact that we cannot go deeper, because there isn't sufficient high quality, larger amount of data that allow us to perfect those prototypes and get them deployed. So I very much want to see, solutions or suggestions from the other side of the bridge, where hopefully we can get better integrated into this fabric.
Sorry, just a quick follow-up. You're saying that there's not enough data, for example, to teach your image recognition algorithm. I'm sure I'm slightly misstating this, but is that because you simply don't have access to it? Because of course there are millions, if not billions, of medical images that exist on the planet. Is it that they are locked away in healthcare systems, or?
Yeah, so this is a very interesting. We often were told that there are millions and billions of data that exist somewhere, but we simply couldn't find it. Basically, they are either locked inside the hospital database system or owned by the creator of the data. And right now, not alone the policy issue or the collaboration channel, even the infrastructure created right now in the medical system for storing those data isn't really working nicely with a solution provider which needs to train those data. For example, how to get a million image out of, say, a current Cerner system or Epic system. That alone is already a technical problem, and we actually even don't know who should be solving that. Is that us, but we don't have access to a database? Is that the data chief information officer in the hospital? I'm not sure, because they are busy with many of the other operations in the hospital. So right now, there isn't a pipeline or there isn't a procedure established to enable repeatable and mass production of this kind of activity in a systematic way. In fact, I think 2 years ago when Steve and under his leadership and also in the CMU leadership, when we create the Center of Machine Learning and Health and Basic Data Science, we have this desire that we want to simplify this whole process. But it is really taking a lot of effort. We are still making progress, but it requires almost a contiguous input from all of us.
Yeah, I fully agree on Dr. Shimbo's comments. Yes, medical images, as you said, medical images in China, they have there's a number in year 2015. That's 1.4 billion scan every year. So a huge amount of data in the hospital. But how to get the medical image data out of that? That's the first question. The second question is that if you get that data, how to ensure that it's high quality? But even given that, Winspan has done a lot of work about that in the last 8 years. So we are collaborating with the hospitals, and also we are creating cloud-based solutions, and also we are finding good radiologists to do some kind of the fundamental work. That is the data collection and the data annotation, and to ensure that data is high quality before I feed that to the machine learning. I fully confident that there's some work we can do to improve that. By leveraging the AI and deep learning. One thing that is the efficiency. The other thing is the reduce the diagnosis rate. The quality is up and the efficiency is up.
I think that's so fascinating in terms of access to data. We work in a lot of emerging market where we collect a lot of image-based data. One of our biggest programs is in India, actually working with Medtronic on ear infection screening. So with an otoscope, we're taking picture of both ears, and we have over 500,000 image data sets. Each of those data is actually first triaged by a health worker that says, is the otitis media, which means a perforation, a hole in the eardrum, which causes the patient to lose their hearing. And then a formal diagnosis from usually ENT surgeon. So what's so fascinating is, how can we work even across different countries where the data is available, there's some triage as well as diagnosis, feed it into the AI and imaging tools, and can we make more progress if we look outside the US for image-based data? I'd love for you to comment on that type of collaboration across borders as well.
Sure. As I said, so in China we have a huge amount of data, and also we create channels and processes to get the data. And also, as I said, we have some radiologists, high quality radiologists, to make sure the diagnosis is right. So that's the baseline. And with that in hand, we can leverage AI and deep learning technology to get some progress. And as I said, we are working with the patent team to ensure that we can find something. Let me give you the example that so far we can do. That is the lung nodule detection. In a typical CT scan, there are about 200 or 300 images to find the lung nodule in every image. That's kind of hard work. So we are creating something to help the radiologist to find those lung nodules automatically, and even give some subjective the size of the nodules. So this work can be done. Sure.
follow up since it's a silence here. Yeah, so we do work with Wingspan on this kind of data collaboration, and I think with sufficient supply of data, there is a hope for the machine learning algorithm to be really powerful. For example, for the X-ray lung image, chest X-ray images, we were able to, in fact, train a system that does better than a human expert in reading out the information. But since the panel is about mobile health, actually I want to maybe direct direction a little bit to that. Mobile health is actually a quite different problem comparing to clinical information, because the information there are a lot more noisy. It is not coming up with a lot of supervision, and sometimes there are other concerns like privacy and securities and other issues. So I actually want to get opinions from our friends from the medical space, how they see the value of this data and what kind of guideline we should follow to make legitimate use of those data.
I'll start. I think when we're talking of one of the big opportunities really for mobile data, but the downside is that if the physician doesn't see the patient, they can't do the physical exam, and they think that's very important. But we're finding out you can do more and more, and when you're talking about the technology such that you could look in the ear and get more real data than you could when the physician actually looks themselves, gives the opportunity to even improve health. So the more technology we have distally that you can get into the physiology of the patient that you might not even be able to get when you're standing by their side with a stethoscope that's probably hundreds of years old, then you have even greater opportunity. It does get into privacy issues, but also somehow these things need to get incorporated into the patient's medical record. There are a lot of different remote monitoring, and we've got stuff you can do on the iPhone with different companies, and then you've got your medical record, and none of these are connected. So what we really need is, hopefully the patient may be in control of it, but certainly a single place where you can synthesize all this information for AI, improving health, but even just for the patient.
Well, I think that I often start to think of this from the perspective of poor countries, emerging markets, developing nations, whatever you want to call them. But in those countries, in fact, probably for almost a majority of people in the world, there is no healthcare system. And so there is no question of integrating the mobile data that these people, that poor people all around the world are now collecting. Sometimes they know that they're doing this, usually they don't. It's just being collected on their phones. But there is no question of integrating this into the healthcare system, because in those countries, for those people, there is effectively no healthcare system at all. And so I wonder, when we look at the United States, or let's say if we look at rich countries in general, we look at poor countries and mobile health, is this going to be a question of, there's nothing economically that suggests that poor countries, for example, are going to be developing a healthcare system along the lines of the United States, or even one that spends a lot less money, that somehow covers most of the population. So in most poor countries, most people will continue not to see doctors, not to go to hospitals, not to see nurses, not to see other care providers. And I wonder if we're going to look at the United States and see the United States as more and more health data is generated by mobile apps. And I think also even the term mobile health, we might have to replace with something more like just or mobile computing with ubiquitous computing, because really it's not a question of mobile phones. I doubt we're all going to be staring into the screen of our smartphones 10 years from now. But in general, we're generating now, we're on the cusp of generating more health data, more health-related data for all of us outside of the healthcare system than we are inside the healthcare system. You begin to wonder, what's the tail and what's the dog? And for a long time, the healthcare system has been the dog, and this little tiny bit of mobile health data that started getting generated about 15 years ago has been the little tail, but now the tail is already 1,500 times bigger than the dog. When we look at poor countries, again, we can see that these countries, they never had the dog, they never had the healthcare system. And I wonder if, in fact, the United States is more likely to move to a system where the vast majority of health concerns are dealt with by non-healthcare related companies, but the healthcare system really becomes very much more explicitly a sick care system where, as you pointed out, when you do get sick, and especially when you get very sick, the healthcare system or sick care system is where you want to go. So again, I see mobile, all these mobile apps and the spread of ubiquitous computing, wearables, all this kind of stuff, and Internet of Things, as being something that is really going to be providing us with better health, whether that's weight reduction or addiction management or health education, completely outside of the healthcare system. And again, the healthcare system will really begin to focus much more on being the sick care system, something it's exceptionally good at doing.
So, how many people ever shop on Amazon? Anybody? And then you look at like a newspaper, the New York Times or the Washington Post, and all of a sudden you see these ads for the product you were just looking at. Maybe it's a shirt, or maybe it's a camera or something else, and suddenly you're seeing all these ads in the newspaper or other websites that you're looking at. So I think that there's a lot of sharing of data. The people who are doing e-commerce have kind of figured it out. I've seen these other stories where I think it was in a movie, I, Robot, a science fiction robot, where they built a woman that this other fellow would like because they were looking at his browser details of what type of women that he searched on and so on. So that's only partially science fiction. So I think that there's a lot that that the commerce people already know about us and can figure out about us by looking at our credit card records and whatever we might buy on Amazon. So that's not to say that the privacy issues aren't important. They are. And I think maybe it might be the way that the data is encrypted or who has access to the data. But I think that the systems, I think something that we need to see, and maybe it'll come out of Carnegie Mellon, are ways that systems can talk to each other. Because I think when you can get the data from your smartwatch or your smartphone or some other device, maybe it's a particular type of scale or so on, into the electronic health record in an actionable way, then you could develop these kind of very powerful systems, that are already there, but the systems need to be able to interact and talk with each other. Right now, we use Epic at the University of Pittsburgh Medical Center, which has probably over 40% of the national market or so for electronic health records nationally at large organizations. And there are ways that Epic has developed where health care organizations can begin to look at other records of patients who are at different systems. But it's still kind of clunky, and I think that we're still on the verge of this changing where it'll be a little bit more seamless. And I think the same thing, and maybe this will happen within the next 5 years, that there'll be a convergence of this data that'll make so much more of a powerful system. With that said, this morning I read in the New York Times that a fellow by the name of Robert Taylor had died. He was 85 years old, and he was one of the developers of the internet back in the 1960s and some other innovations. And when he got to the Pentagon in the 1960s during the Vietnam War, there they had I think you said in the obituary this morning, there were 3 big computer systems, but none of these computer systems at the Pentagon talked to each other. So eventually he worked on a problem that became the internet through ARPA, where they funded these systems where there were internet protocols and other kind of things where these computer systems can now talk to each other. And I think we're kind of on the verge of seeing that in healthcare. It's not quite there yet, but hopefully over the next 5 years or 10 years, by the time some people in this room have finished their postdoc and are ready for their faculty or industry positions, will be there.
Thank you for the comment. And I think you brought a really important point. Only if we can share all the data that we need, have them accessible at any time, we could solve the problems in healthcare. And what's interesting, there are 2 perspectives where I've seen this. One, I grew up in Taiwan. They actually truly have an integrated healthcare system. With my national ID, I can go to any hospital. They'll look me up. They'll see my entire medical history. I don't need to carry any records around. They'll know, oh yeah, I see Dr. So-and-so in that other hospital did this. Here's how I would, change the regimen or whatever. I mean, that's truly a model, and it's a new system built, based off of every other healthcare system, and say, how can we build the best interoperable health system for, much smaller country? So that's one approach. I don't see U.S. getting there anytime soon. But another approach I would love to hear your comments on is, in places like Africa, when we work with HIV patients, everyone had their booklet The booklet is where they write down when they go see the hospital doctor, here's what the hospital said, here's my diagnosis, here's my pills. When they go see somewhere else, it's the same booklet. That's really the concept of, what we would have would be our iPhone has our patient medical health record. I mean, do you see that as something more viable here or more the Taiwan approach? Love to hear your comments on, how do we get there, the, accessibility to data so you can actually make the right medical decisions.
I think you point out the very important thing, that's interoperability. As I know, in USA they have done a lot of work to ensure the interoperability. As I remember, there's a meaningful use stage 1, stage 2, this kind of work, and also the government has kind of reward who are adopt the meaningful use of the system. I think that's a big problem. The first thing we should do from the industry or from the academic area is that we should set up the standards of the interoperability. The second thing is from the government who should stimulate that thing. And also, there's the third thing is from the vendor perspective, like we spend, we should follow the standard, because when you talk to the other system without a standard, it's kind of the you cannot get the data.
Maybe I should add, I was in Boston 2 weeks ago, and I was talking with the Boston General Hospital and also many scientists, from physicians over there. One of the biggest complaints I heard is that even in a single city, in a single hospital system, different hospitals will be using different database systems which are intransparent. So I very much agree with Bruce's insight about interconnectivity between the organizations. But who has the key to that? That's the question right now. I think the fact that in here, Epic and CERN are being the monopoly of the database provider is right now, to me, creating a problem, because these companies refuses to open up their system for external developers, and then they have a huge profit already. There is little incentive for them to go themselves to provide this connectivity. And so that's why I'm actually more optimistic to see systems in Taiwan or in Africa even, where there's nothing, there's no infrastructure over there. You start from ground zero. There is actually even an easier and cheaper process to have this infrastructure. So to my own kind of opinion, right now even I'm getting data outside of US in an easier fashion. And I also see deployment and interoperability between different silos, in the hospital to be more easy, actually easier, in elsewhere. I think the United States has this challenge to address now, to both at the policy level and also at the technological level, how to kind of bridge together, different islands, in the hospital ecosystem, both, in between the hospital organization and also even in the infrastructure and the software and databases they are using. And it's more than a technical problem. In fact, it's not an AI problem at all.
So, I completely agree with you that within the healthcare system, Cerner and Epic, have staunchly resisted exchanging data. There's no question about it, and it rankles even more when we realize that it's our tax dollars that have been spent to provide these huge profits to these companies, which then don't allow their data to be shared. But again, I would caution, I'm repeating myself, I think, but I would caution against focusing on the healthcare system, because after all, the topic of the panel is mobile health. And I don't think anyone who's involved in mobile health thinks that the healthcare system 10 years from now is going to be the main player or the majority player in mobile health. It will be a player for sure, but it's not going to be the leader in mobile health. And so I think right now, because every time we think about health, we immediately think about healthcare. And this gives the healthcare system a larger weight in our thinking than I think it actually deserves. Because as I said, for anyone in this room, for most of us certainly, and definitely the young audience, the majority of their health has nothing to do with the healthcare system. And so I think what's going to happen as more and more companies are developing apps. We discussed this app that was just developed and approved by CDC, or given a stamp of approval by CDC, that helps people to lose weight, completely outside of the healthcare system. It's just the beginning. As we have more and more startups, more and more people, perhaps in this audience, creating apps that positively affect people's health, we will find ways for the government to approve these apps to be used, and a larger and larger portion of our health data will be outside of the healthcare system. Right now, Cerner and Epic dominate because we keep thinking of the healthcare system as the center of the world. But Cerner and Epic won't have the leverage to dominate once 90% of health data is generated by apps that have nothing to do with the healthcare system. I think that's going to solve the problem. Again, right now, every time we think of health information, we think of Cerner and Epic. It's deceptive now. It will be even more deceptive in the future.
So Joel makes a great point that much of the information that's coming to the health of the patient is not within the medical system, but I do also see a time when the health care data itself will be liberated from the EHR, and the patient will have access to that as well. You see, we talk about consumerism in healthcare, and it's not just a word. The reason that it's real is, if you think about it, going back to the problem that I talked about initially, that healthcare costs the nation too much. Before the Affordable Care Act, the way in which big companies and the government who pay for healthcare have started to address it was with insurance companies changing insurance benefit design with high deductibles, co-pays, co-insurance. In other words, the patient is now having to pay for more and more of their health care. And the more that you create a price-conscious consumer, the more interested they get in their health care, and their data. So we've now incentivized people. Before, nobody really cared. Somebody else paid for it, and it's okay, do what the doctor says. Now, you trust the doctor, of course, but you really trust but verify. So I do think that there is a movement with consumerism so that more of the data is going to move to the patient. Now, having said that, even physicians want to be liberated from these EHRs. One of our NLP companies are these called the Israeli hackers. We can get data. I think the government is going to force more sharing, but in the meantime, we're going to need good hackers like you to get that data in and out, because it is a monopoly.
So I think the standards is really key for the mobile health, and I was just thinking about give another shocking analogy. When you go to Home Depot, you see all these light bulbs, right? And I was just looking at the light bulbs over here, and you have the compact fluorescent, the LED, and the incandescent, and they're made by different companies, Sylvania, and GE, and so on. And I think it'll be like that for the, hopefully, for the electronic health record and the mobile devices that link into that there'll be standards. So any of those light bulbs would screw into a regular, 110, 120 volt socket in your home or office. And you could buy them from different manufacturers. So it'll allow for innovation, and companies will compete on quality and price and feature set. But we need to have that kind of a subset. Now maybe it might be government stepping in to require people to open up the system to some extent, otherwise we get duplication. But I think there's a history of this. The other similar analogy is with the VCR. I think people are using these less because of streaming, but in the 1970s, and so there was a big competition between the Sony Betamax and the Philips VHS. Was it VHS? But they had two different competing standards for doing basically the same thing, watching movies and recording at home. And eventually the market kind of sorted itself out, and it wasn't even the best quality product. I understand the Philips that won over the Sony. But I think we may see something like that over the next couple of years, because as you were saying, it would be difficult to, for the government to sustain these systems in parallel that don't speak to each other.
And we talked earlier about if you throw a lot of money at a problem, you'll get a solution. And I'm sure you're all familiar with the X Prize, the Qualcomm funded X Prize. And a tricoder was born where it can detect all the different vital signs and symptoms, and it comes with an app, and it can be used, by providers and adopted by consumers. I mean, what would you like to see as the next invention? And I think also very importantly, who would be the user of that, and how would it be adopted?
So I've been thinking a lot about food, and people eat several times a day, and I've been really interested in the idea of a mobile app that's a visual food diary, so that people could take, not barcode scanning or where people are, I see these apps that advertise you have 80,000 or 100,000 foods that you can pick with from a drop-down list, but something that you take a photo of the food and the software can analyze what you're eating, or maybe you take a picture of your refrigerator and a dietitian or somebody can look at the look at the food in your refrigerator using that kind of machine learning to analyze the food, or at the very least a timeline. Because I don't think people want to do scans of all their food or go for a drop list. And I think food is something that we eat every day. So if we could develop these kind of things, and then maybe they could be linked to these behavioral economic incentives to make smarter choices. And I would love to see that. And if anyone knows about anything like this that exists or they're working on, please drop me an email or a text or something. I'd love to learn more.
I will talk to one. And one of my friends, Kevin Murphy at Google, is doing exactly the food app, which tells you the calorie amount, the level of nutrition, and so on. I think there are actually quite a few startups and activities in that space trying to use computer vision to address this kind of mobile kind of interfacing health-related problems. I don't see them being successful yet. Part of that is, of course, the problem itself is very hard technically to recognize all foods, especially the foods you have never seen before, and also, what if you run into a messy, refrigerator versus an organized one? That's also a different problem. So there are problems in that space. And then the other space is the deployment and also the standardization. Who we believe and how to test the practice and how to regulate all this one. One company may recommend you this food is good for your health. The other one says no. And we don't yet have a roadmap or maybe a regulation to govern this kind of definition. So I think this probably will be a co-evolution process with people like you who are interested in this kind of app, and also can authoritatively give back feedbacks to be in that loop for you. Right now, one thing I told Kevin that he's unlikely to be successful in that venue is that there is no doctor, no consumer involved in that development. It is kind of one team fantasy out of geeks and engineers. And I don't think a great application or great product can be produced in that.
I was just going to add to that I know that also several supermarket companies are working on apps that basically they're working on loyalty programs or already have loyalty programs where, for example, if you shop at the Whole Foods already knows when you check out, it knows exactly what you bought, and to somehow use that and provide that to you in a useful way that might help you understand your health just on the basis of what you had from the Whole Foods. Now, of course, what would be even better is if the Whole Foods and the Trader Joe's and the Safeway were able to standardize or come together with something that provided you with the whole picture, and then they took Open Table and rolled into restaurants as well. I did want to make one comment using that as a lead-in in terms of standardization, because I think there's, like you, I would love for the government to step in and mandate standards for the exchange of health information. I'd love for that to happen. But remember, it's the same government that gave us the current EHRs that we have now and allowed them up to now to not share data at all. And so I would say mildly skeptical as to whether that's going to happen, even though the need for it is so obvious. But I think there's also some reason for optimism in recognizing that it is absolutely possible to provide us with aggregated information without, in fact, having standardization. When I came here from Washington, D.C. this morning, I used an app called TripIt. What TripIt does is when I schedule a flight, for example, with American Airlines, the email gets forwarded to the TripIt web application, and TripIt takes it and puts it onto my calendar on my iPhone, so I don't have to type in the flights. TripIt works with every single hotel I've ever heard of. TripIt works with every airline I've heard of. These airlines do not use a standard for the creation of emails that, if you get an email from United Airlines confirming your flight, it looks totally different from the email that comes from American Airlines. And TripIt, when it was built, looked at that, and I'm sure they wished that there had been standardization, but TripIt as a startup was not in a position to demand that major airlines and hotel companies produce standardization. So again, it's kind of like us as physicians and patients. We're not in a position to make these EHR companies standardize. So TripIt just solved the problem by brute force. They just had programmers look at the emails from every single hotel and every single airline, and they put it together in a system that works flawlessly. I've never had a problem. In a similar way, although it's a little bit more standardized, I'm sure that many of the people on the panel, I don't know about the young people in the audience yet, use financial aggregation programs like Mint.com or Personal Capital or Betterment or all these others. And these all, if you give them access to your financial companies, your financial accounts, they will provide an aggregate of that. Now again, there's more standardization in the financial system than there is for airline emails to me, but it's not completely standardized. And so Mint.com, for example, used a combination of utilizing the standardization that exists, but also working around the lack of standardization simply through brute force tackling of the problem. So the fact is that if we could just get the EHR companies to open up, just make it available, even if it wasn't standard, we could brute force a problem to provide that aggregation. You know, we don't have to wait for that to happen, even though I love it for it.
I think we have a lot of very, very interesting thoughts, and for the audience, and I think many of you are students as well as professional, maybe you can tell us more about, you know, within Pittsburgh itself, there is a great ecosystem. You know, we've got UPMC, we've got incubators, we've got startups, we've got professors, we've got knowledge and hackers and everyone else here. You know, what is one way to get started if someone's interested in mobile health development? How do they even get into the field? If they have a solution, how do they vet it, and how can they work with, you know, any of you on this?
Technology problems. It is on. It says it's on.
I think in the future, you know, the big problems, we talked, going back to your last question of if you just throw money at it, what do you really want to do? Well, we throw a lot of money at trying to cure chronic diseases, for example. We haven't done a very good job. And part of that is that we just don't quite have the knowledge. Our sort of hypothesis-based approach gets us just so far because we don't know what we don't know. So the really big opportunity is really the combination of understanding these disease processes with the emerging omics data, from genomics to the microbiome to you name it. It's the accumulate and the clinical data and the social and the demographic data. The more data we have, the better our ability to really understand these diseases are if you add the right AI, and I'm not even sure we've got enough mathematical expertise to apply broad omics to a multidimensional, asynchronous temporal problem like healthcare. But if you want to get involved, those are the big places that we need to solve these problems. And from the mobile health standpoint, the more physiologic information you can get from a patient at a distance and communicate it back, the more healthcare we can provide outside of the delivery system.
Okay, maybe I should say a different message. So we are a startup and we are hiring. So if you want to get into this space, please just send your resume to me.
Yeah, I think a key thing to get involved is also to be multidisciplinary and to try to get out of your silos. If you're an engineer and you're in the crowd, a software engineer, then I think it's important to walk across the campus and work with somebody from marketing or the Human Computer Interaction Institute. I think that's one of the panels tomorrow afternoon around this time. So I think it's really important. I'm a primary care physician, so it's almost like being a 10-in-1 wrench, where you have to work with people in different departments, statisticians, cardiologists, psychiatrists, psychologists, and so on, to kind of get things done. So I think, you know, if there's a key message, is that the best things from tomorrow are going to come with teams working together. There's a key book, I'm blanking out, the fellow who wrote Walter Isaacson wrote a book the other year that came out called The Innovators, which was about the computer industry dating back from the 1840s, and Ada Lovelace, who was the daughter of Lord Byron and a mathematician in her own right. And it kind of chronicles the history of computers to the present. And basically, it wasn't just the lone inventor who was by himself or herself, but it was really teams of people with complementary skills. So I think the key thing and what's unique about being in Pittsburgh is that we have people here, at University of Pittsburgh, at UPMC, across Carnegie Mellon, who have those kind of skills that you might be looking for. So even, we're just a short walk down Forbes to find what you need. So I think that's the key thing. Create your team and walk around campus, walk around the area to find your colleagues.
Maybe to add on to that, when I was in this class at MIT Development Ventures, we actually did an approach where literally I said, I'm interested in mobile. Someone said healthcare across the room. We're like, well, that's a good idea. Let's form a team. So we literally just, formed a team off of very similar ideas. And I'm sure also at Carnegie Mellon, there are innovation challenges, there are hackathons, there are endless number of opportunities. I myself got a grant from MIT to literally backpack across Africa with my little mobile app and pilot it with the different clinics and learn that, did this application help connect doctors from the US and help them do a diagnosis or suggestion for diagnosis for patients with HIV in Africa. It turned out to work, and that took a lot of collaboration. We worked with UPenn, we worked with other universities and MIT, and engineers, PhD students, to really make it happen. So I think whatever ideas you have, there are so many avenues, especially from Carnegie Mellon, to take the next step. And you've got your PNC and all the other panelists that you've met here today. And I think just, as the last remarks, we'd love to hear from each of you tips for our audience, whether it's about what you think the future of healthcare would be, the coolest mobile app, or how to get started on your next healthcare venture. I'd love to hear from you. How do we help spark interest in this field for the audience?
After my graduation, all my work experience is all about the healthcare, and even to me, I think I'm very new to this business and this area. So what I'm trying to say, healthcare is a kind of life journey, and you can do a lot, and there are a lot of questions, a lot of problems behind them. You can do to solve them, you can do improve them, and to me, I think it's kind of the endless journal. And but I think we are with the technology, mobile technology, cloud computing, and also the machine learning, AI, those kind of stuff. We are improving every day. So welcome everyone to join this journey.
Very much agree. I would only say that when you and I first bumped into each other, which was I think 2009 at MIT. I was there talking about the company that I started, Magpie, and one thing that's really astonishing to me, and this is a big difference between when I was in college and with all of you in college or in graduate school, is that back then we didn't have a delivery system for software that reached to the individual around the entire planet, whether that's rich individuals or relatively rich people in the United States, or whether that's people in middle-income countries, or whether that's the poorest people around the world. We didn't have that, and so it would have been literally impossible to design any kind of a solution that you could get out to those people. But now, and when I say now, I mean really just in the last 5 years, I've seen as a physician working in poor countries that we've gone from 10 years ago, every health worker in Africa went out and bought a basic mobile phone. And then 5 years ago, every health worker in Africa went out and bought a smartphone. And even the village health workers went out and bought basic mobile phones. And now, at least every household in the poorest countries on earth, if not every person, but at least every family, has a supercomputer connected to the internet that will run software that you can write. And the idea that you have this direct connect, that if you can build a compelling app, and hopefully one that affects people's health in a positive way, whether it's here, or it's in China, or whether it's in Africa or Southeast Asia, again, that would have been an impossible dream for me as a college student. And now it's very much a reality. I hope people really understand this idea that you can tap directly into the population of the world in a way that simply wasn't possible even just 5 or 10 years ago. Really quite miraculous. And again, something I think we all need to think about as we try and think about exactly who our audience is and what the business model might be to reach that audience.
It's great. Following up on that theme, first of all, being involved in healthcare is extremely rewarding. One of the more frustrating parts was that we would like to do more for our patients. And the good news is our biological knowledge keeps doubling every couple of years. Computational power keeps accelerating. So during your careers, the ability to really improve patients' health and disease is just unbelievable, and it'll be extremely rewarding, whether it's the biological sciences, taking care of patients, or the computational side. But it's going to require both to solve these great healthcare problems, but they're solvable in your lifetime.
So I guess in the audience, maybe there are two types of audience. The one is the young students and beginning entrepreneurs and engineers who are looking for opportunities, and the others are the investors who want to seize opportunities to accelerate the success. For the first body of audience, my advice will be you need to keep learning, especially in the space of AI and say its application in healthcare. There are more unknown than known. And there are, a lot of space to develop new solutions. And I think as a young student, even after graduate, I would really recommend you to keep your eye open and grasp new technology and new knowledge. For example, right now there is this perception that maybe deep learning is ruining the world, and you just need to learn TensorFlow or a certain language, you will be finding jobs and all that. This is not true. I think in the future, there will be more tools needed, there will be boundaries. In fact, it's already there for many of the existing solutions to be incapable of delivering the right answer. So for people who are going out to try to conquer the world and generating new opportunities and solving new problems, you have to really equip yourself with the sufficient knowledge in AI, in mathematics, in applied science, and also in the specific problem domain. Then for the investors and for the senior people who are trying to help with the youngers and so forth, I think the most important thing is to try identify the right problem. There are so many problems out there, and it is beyond our capacity to really solve every one of them. And also there are a lot of hypes, especially in China. In fact, the media is playing such a big role. Unlike what we see in the US, in informing people about all sorts of information. Most of the information are misinformation, in fact, and there are a lot of how should I say, hypes and bubbles and in-serious discussions about the opportunities and about the problems. I said a few of these problems this morning in my talk about some of the misconceptions in AI space and in medical space. I think there are more beyond what I can discuss, but for senior people, we should have our own judgment about all this information, and we shouldn't be misled or just guided or rely only on social media or what the written story was trying to tell you. You have to digest the information and form your own opinion. That's my suggestion to the audience.
I'd like to echo what Eric said. One of my favorite quotes is by Louis Pasteur, the French bacteriologist, about chance favoring the prepared mind. And so as a result, I try to read broadly. I go to different meetings like this one and meet different people, because you never know when you might find an idea that'll inform what your work, and not just to read within your work, if it's computer science or something, but to read broadly. So I try to read the New York Times every day, computer magazines, as well as magazines in my research field. The second issue is someone else said, I can't remember who had this quote, about nobody ever went broke underestimating the American public. And I think what I mean by that is many of the patients that I see are not as educated as the people in this room. I think it's only about 35% or so of Americans have a college education. There's a lot of poverty. There's a lot of there's just a lot, we can't just be inventing things for people with college degrees and PhDs and other graduate degrees. To really affect public health, we really need to think about, what can we develop and design that could be used by the majority of people and not just a thin slice if we're really going to move the needle on public health. What are programs and projects that are big and that people will engage with and excite also the people that you work with? I think if you can keep that in mind, you're likely to all do very well. Thank you.
And we can open the floor up to any questions the audience may have. You can raise your hand, we'll run them up to you. And there are some questions that we received, and particularly one that's somewhat interesting that we didn't really touch on. That was, what specific things can wearables track and how would it be used? If any panelists would like to comment on that.
So again, the question was, what things can wearables track and how might that be used? An impact on health outcomes, sure. So I gave a talk a couple months ago at the Orthopedic Research Society. So orthopedic doctors are involved in the study of bones and the body's motion, and often are involved in sports, etc. And I gave a talk to about 500 orthopedic surgeons and orthopedic researchers. And someone in the audience, after I gave a talk about mobile health and the uses of mobile health, they said, okay, well, but I mean, we're already using lots of different stuff. How can this, we're already doing, I think, everything we can. What more might we do? And I said, having spent 2 days at the conference and having spent at least a couple hours in the poster sessions, looking at hundreds of research posters, I said, in all the research posters, I didn't see anything that used data coming off of a smartphone. Now, this isn't an internal medicine conference. It's not a conference on obstetrics. It's a conference for the doctors and the researchers that focus on motion of the human body specifically. And the fact is that every single person in the audience at that conference, just like every person here, just like every single one of the patients and every single one of the study subjects, is for the first time in human history carrying a device which measures the amount of motion how much do they move, how fast do they move, in which direction, etc. This was specifically an audience of orthopedic researchers. The iPhone came out 10 years ago, and no one in that audience had even been looking at the most basic data coming off the mobile phones carried by every single person that everybody in that equation knew about. So sure, I think we can think about wearables measuring our heart rate. Apple apparently is working on measuring glucose levels somehow non-invasively, and this is all amazing, miraculous stuff. But I think at this point, we're really not, for the purpose of medical research at least, we're really not even using the basic data that's been coming off of our phones for 10 years.
And another very interesting question from the audience was that some say the problem that solves all problems is sustained behavioral change. What in your experience or estimations might be effective at motivating adherence and long-term behavior change?
Your mother or grandmother might also affect long-term change on a serious note. I think some of the things are changing the environment. So how, the built environment, how that go beyond just what people can do, but so that we can make better choices. Choice architecture. I read these stories about marketers. You go to a supermarket and people subtly place food at eye level or need level, and that influences buying decisions, even though you're not doing anything to educate people. So I think a lot of it is going to go from we talk about this with the social determinants of health. I live in Squirrel Hill. It's a nice neighborhood. We have sidewalks and parks and so on, and so it's easy to get around, and the neighborhood feels safe. So I think it's those kind of changes beyond the healthcare system, but it might be public policy, zoning regulations, and so on that I think can really make a difference and changing the built environment. Although that's going to take a long time to do.
Thank you. And we talked a lot about consumer technology. This one question is also interesting. The question asks, at what point would we see patients contributing to their own medical record with their Fitbit data or their 23andMe results? How do you see that evolving? And are those data actually useful for helping persons to become healthier?
There was an article that just came out recently from the University of Pittsburgh showing that not necessarily if you got your 10,000 steps and then go and ate a whole bunch of other stuff and thought you were done, it wasn't necessarily the answer. So I think it's really a combination of things, which gets back to the behavioral aspect of things. So really education is critical, and even that, some behaviors are really difficult to it's really, smoking, for example, is the most addictive substance in the world, and we do need a lot more research around how to break some of those behaviors, because just telling someone not to smoke, or someone who's 100 pounds overweight, just giving them healthier foods is difficult. So part of the continuous monitoring and the health apps would be reminding patients continuously, or having them, sometimes if you take a drug for hypertension, you don't notice, you're not symptomatic from hypertension until you have heart disease later on, or kidney disease. So there has to be some sort of reminder and education that is necessary to make these things work.
Great, thank you. And I think I feel like I've just gone through a flight over history and the future and AI and all of the exciting technologies, mobile health and healthcare systems. And I want to thank you, our panelists, for such insightful thoughts. I also want to thank our audience for such interesting questions. And this does conclude the conference for today. And thank you very much for everyone's contribution.
Yeah, again, thank you everyone who come to this conference today, and thank you for staying so late. Tomorrow we'll have a full day of other kind of events, including new venture challenges, so as job fair. So I guess it will be even more interesting. So we look forward to seeing you again tomorrow. Thank you.